Hi everybody, it's Professor Miller. This lecture is going to cover the neuroendocrine system or the introduction to it. I will cover some portions of it too, like the thyroid, to kind of put it together, with some abnormal disease states. So we will cover more of it within the next PowerPoint as well. So in terms of your endocrine system, it's really a interaction between your nervous system and your endocrine system, and basically secretion of hormones. Obviously, there's a lot of different functions of various portions of our endocrine system, and depending on which hormones are secreted. But a lot of it has to do with our metabolism, our reproductive system, growth and development, coordination of the reproductive system, things like the menstrual cycle, areas like that, and maintenance of your internal environment, or basically homeostasis, and adaptation to emergency demands on the body, so like stress or illness, and we'll talk about that as well with like cortisol. This is just an image that kind of covers each area of the endocrine system. Obviously, there's lots of different glands, but really when you think about this, it's really, really important to understand the concept of your hypothalamus and pituitary axis. This essentially is kind of like the higher level of control over our endocrine function in our body. So you can have areas that present within the gland, like the thyroid, for instance, or you can have an issue that originates up in the hypothalamus or pituitary gland. So they're kind of the controllers of a lot of our hormone synthesis or secretion, essentially. So I'm going to try to put it in perspective, and that's why I wanted to add the thyroid in here, because I feel like that's one area that people are more familiar with, so that you understand how it kind of all interrelates together. And then we'll also talk about the parathyroid briefly, the thymus, which we kind of talked about with our immune system, so we won't cover that too much right now. But we will look at your adrenal glands, obviously your pancreas, and when we look at diabetes and all that as well. The hypothalamic pituitary axis, like I mentioned, is basically kind of like that higher level of control. They're very related anatomically and functionally. They're right next to each other. And essentially, this is what is regulating all of those processes and all of the release of hormones. And obviously, as I mentioned, there's a lot of different hormones and regulation or factors that are regulated by your hypothalamic pituitary axis. So they kind of work in concert to stimulate your hormones. And when we look at the pituitary, we look at the anterior pituitary and the posterior pituitary. Your anterior pituitary is kind of, it pretty much has more, it controls more of the endocrine system essentially versus the posterior pituitary. So we'll cover both of them, and I'll kind of explain that as we move through. But your hypothalamus basically is what stimulates your pituitary. Your pituitary then stimulates your glands, essentially. So just kind of keep that in mind as we kind of move through this. This is a really, really good image to kind of look at, and it puts it in perspective of what exactly I mean by basically that higher level that's kind of controlling all of our other systems. So once again, you have your hypothalamus, which actually has a lot of other, maintains a lot of our essential body functions, but it also has a lot to do with our neuroendocrine system. And anytime you think of the hypothalamus, we look at the hypothalamus as the area that basically sends these releasing hormones. So anytime you see like the thyroid, and I'll show you in a few on a different slide, but that's what's stimulating the pituitary. Then the pituitary sends out stimulating hormones. So the stimulating hormones are what stimulates the glands. So hypothalamus is releasing hormones, pituitary is stimulating hormones, and then that's what goes to the body in certain areas. And, it's actually a very complex system, but it's very, very regulated as well. It can target certain areas, obviously, with certain, whether we're stimulating growth hormone or prolactin, it all comes from one area, and it targets those areas. As I mentioned, the anterior pituitary has more function in terms of the endocrine system instead of the posterior. So your anterior pituitary, which is right here, has functioning for all of these areas, whether it's your thyroid, your adrenal glands, prolactin levels, your growth hormone, which is basically targets all your bones and tissues, and then also your reproductive system. So like your FSH and LH, those are what regulate, like the female reproductive menstrual cycle, essentially. So like I mentioned, we're kind of looking at it from three areas. You can have a problem that originates up in the hypothalamus, you can have a problem that originates in the pituitary, or you can have a problem at the actual gland level. So you can have, if it's at the gland, like just for instance at the thyroid, you can have, the thyroid may dysfunction, whether it's, from Graves' disease or an autoimmune process. So it can originate there, or it can originate higher up. And there's even medications or things like that that can actually, cause problems, at the glandular level as well. Your posterior pituitary over here is basically the same kind of thing. It's, it's stimulated by your hypothalamus down to your posterior pituitary, which basically goes out to your, the two things that it pretty much functions is oxytocin and antidiuretic hormone, so your ADH. So your posterior has, significant control over those areas. So like oxytocin is actually what, like when you get into OB, oxytocin is what contributes to smooth muscle contraction in the uterus. And that's why, like if you think about someone that gets induced when they're pregnant, we give them oxytocin. So it causes smooth muscle contraction in the uterus. It also causes the release or letdown of breast milk when a mom's breastfeeding. So if you look over here, prolactin is basically where milk production is occurring from, where oxytocin is the letdown reflex, essentially. Your antidiuretic hormone, which I know you talked about previously with like the cardiovascular system, obviously is very important to our fluid volume. And we'll cover this briefly in this video, and I also will cover it within the next one as well. So just kind of look at this image and, look at the different levels here. So a lot of them are secreted essentially with a specific rhythm. So obviously there's that feedback cycle, and it's really, really important to understand negative feedback because that's basically what's controlling a lot of this. But when you think about like a pulsatile or cyclic, just think about like the female reproductive system. Obviously, it changes, throughout the month, or even you think about like your adrenal glands and cortisol release. It basically is released dependent upon the needs of the body, essentially. As I mentioned, it's very specific and it only targets certain receptors, meaning receptors at like the organ or the gland, like to release hormones. And obviously, too, these hormones are excreted by the kidneys, or often sometimes deactivated by the liver. Regulation of hormone release. So basically, it's a response to an alteration in the cellular environment. So it's a negative feedback mechanism, which I'll show you in a few slides. And it's essentially to make sure that all of our hormones or these substances are regulated at a level that, basically maintains a state of homeostasis. So they're regulated by chemicals, hormonal, or neural factors. So the neural, where I mentioned like the hypothalamus, and it signals down to the pituitary. So it's all of these things that are put back together. Negative feedback is what essentially kind of controls this. And I'll explain it to you when we go through the thyroid. That's why I wanted to add that in here. Because it's almost easier if you think about it when we actually put it together with, an actual hormone. So I'll explain that as we kind of move through. As I already mentioned, the hormones of your anterior pituitary are like your growth hormones, corticotropin, thyrotropin, your FSH, LH, prolactin. And these are basically what are, stimulated from the anterior portion. Your posterior, like I already mentioned, is oxytocin, antidiuretic hormone. So you can have, hormone dysfunction at the level of the gland. I already mentioned this. Or you can have a defect in that hypothalamic pituitary axis. Or another common cause is like a pituitary adenoma. So if you have a tumor of the pituitary or dysfunctioning of the pituitary, obviously it can affect release of the stimulating hormones from there. So it can be caused from something higher up than, just the gland in itself, if that makes sense. I worked in neurosurgery before, so we saw a lot of pituitary tumors and a lot of patients that had transsphenoidal pituitary tumor surgery. But a lot of them would present with dysfunctions of their hormones. Their hormone levels will be way off. And when we look at, abnormals, we got to figure out whether it's at the gland or if it's at a higher up level, basically with whether it's primary or secondary, which I'll explain too as we kind of move through. But like I said, that sometimes they present with like an abnormality resulting from, a certain hormone. Like prolactin's a good example. Some patients would present with galactorrhea, where they have, secretion of breast milk when they shouldn't be. So we would, evaluate their prolactin levels, and we try to determine, obviously, where is it coming from, and why is their prolactin levels high if it shouldn't be? Because sometimes that's kind of how it'll pop up. Posterior, like I mentioned, it's basically your antidiuretic hormone and oxytocin, and I already kind of talked about that. But a lot of these are essentially synthesized like in your hypothalamus, but then it's kind of secreted down by the posterior pituitary. So it's stored there, basically synthesized in the hypothalamus, stored in the pituitary, then secreted. I added this. This is a great image to kind of put it together. Like it's the same things I've already been mentioning. But the really, really important concept, like I already mentioned, is understanding negative feedback. So like you have your hypothalamus, your pituitary, your anterior and posterior. So let's just look at the anterior. Always remember your releasing hormones are always started by your hypothalamus. So just remember releasing is hypothalamus. Your stimulating hormones are always from the pituitary. So your stimulating hormones are what stimulates the gland. And then obviously once it stimulates it, that's where you get release of the hormones. And obviously each one has different, stimulating factors. But like I mentioned, releasing is here, stimulating is here, then it goes out to your glands, and that's where you get the hormones. So now when you have negative feedback, what it is essentially is that, let's just look at the thyroid. Your pituitary, basically, if it releases TSH, so stimulating hormone, to put out T3, T4, which is your thyroid hormones. Well, your hypothalamus and pituitary essentially sense, or they know whether or not your thyroid hormones are normal or low or high. So let's say they're low. Well, your hypothalamus will sense this, that they're low. Then it basically outputs again saying, okay, let's send out releasing hormone, and then have it trigger the stimulating hormone to bump up those thyroid hormones again. So basically that's what negative feedback is. It's basically these levels are kind of controlling what is sent back and whether or not it should turn on or turn off. So if it's low, it's going to turn it on. If they're really high, it's going to turn it off, if that makes sense. And I'll put it together with the thyroid. So like I mentioned, your hypothalamus is releasing hormones. So TRH, you're basically your thyroid releasing hormone. And this stimulates your pituitary. These releasing hormones stimulate the pituitary. So then once it does that, your pituitary basically sends out stimulating hormones. So thyroid stimulating hormone, which is your TSH. In the thyroid, we always look at the TSH levels because it tells us whether there's a problem at the gland or up in the pituitary, essentially. So negative feedback, basically it's each step from the previous one, it can tell whether it's high or low, like I already mentioned. And a good example is like a thermostat example, and I'll show you that at a few slides. But really, it's really important to understand negative feedback in order to understand the lab values or where the abnormal is originating from. As a nurse, it's not really your job to figure out where it's coming from, but it's always good knowledge to have and understand. Obviously, like a physician or the primary care provider is the one that, is figuring out where the abnormal comes from. But as a nurse, you really should have a good understanding of this. And it makes more sense when you understand it. So like I mentioned, these hormones, like your T3, T4, are what controls the hypothalamus and pituitary to turn on and off. So here's an example. Your hypothalamus, your pituitary, and then your thyroid. So once again, your thyroid levels, like your T3 or T4, your hypothalamus basically senses this like a thermostat and will turn on or off based on whether it's high or low. And if it's low, then it's going to stimulate and then increase more, if that makes sense. Your thyroid, obviously there's parathyroid glands too, and we'll talk about this in the next PowerPoint, but your thyroid is located in your neck, right on the sides of your trachea, essentially. So they're basically right on both sides there. Your parathyroid glands are kind of tucked right underneath there too. Your thyroid essentially basically is used to stimulate energy. It has a significant effect on a lot of different body systems. It has a significant effect on your cardiovascular system, growth and development, whether it's your GI tract, your skin, your metabolism. So when we go through abnormals, I'll show you, but you can put it in perspective of how much it affects, essentially. I added this because I thought it was a good area to kind of look at, and it explains basically T3, T4, which are your thyroid hormones. In United States, we don't really have a lot of issues with iodine deficiency just because of our dietary factors. But in underdeveloped countries, a lot of times thyroid dysfunction originates from lack of iodine intake, because iodine basically supports your production of T3 and T4, essentially. So that's not really an issue in the United States. We have more problems with like autoimmune diseases that cause, hyperthyroidism or hypothyroidism. But in underdeveloped nations, iodine deficiency is a significant problem still. But T3, T4 is obviously what, our body uses to continue metabolism, essentially. I added this because it gives you an example about like the thermostat example. Just as I kind of mentioned, like you're releasing hormone from your hypothalamus and your TSH. Basically, it's kind of like a thermostat. So if you just read through this, but it gives you an example of like how your thermostat in your house turns on, when it senses it's too cold or too high or too hot. It's the same kind of concept when we look at the thyroid, essentially, with the hypothalamus. As I mentioned before, you can have, and this goes along with a lot of the issues with your endocrine system, because a lot of them kind of go through the same tract of your hypothalamus and pituitary. So if you have problems with your pituitary, you can have problems with multiple endocrine hormones. But when we talk about primary basically is at the thyroid. So the thyroid is having a difficult time producing hormones. So the pituitary is functioning normally, or your hypothalamus. It's basically telling the thyroid, hey, we need more. But your thyroid, might not be producing hormones properly, or they may be overproducing. So primary originates right at that thyroid. Where secondary is where it's originating somewhere above that. It's originating, usually the pituitary is where the problem is. So the thyroid's not being stimulated by the pituitary. It's not releasing that TSH for the thyroid to work normally, essentially, to produce these hormones. So there's a complete difference there where it's originating from. And, as like a provider, we have to figure out, okay, where's the problem originating? And we do that by looking at like lab values. This is just a good example. So like if we always use the TSH to screen. Everybody should have TSH levels. It's very, very important in females. It's more common in women to have thyroid dysfunction. Not that it's not important in men, but screening is typically done on all women. But if you look at the normal results, what we look at is TSH and T4. We tend to look at T4 more, and we always, in fact, like if a patient has hypothyroidism, we actually replace T4. That's what we tend to replace. But if they have, normal function, their thyroid stimulating hormone should be normal. Like it should be in a normal range. It should all be in concert with one another, meaning that it should all work together. And your thyroid, your T4 hormone should be normal too. Whereas someone had hypothyroidism, basically let's say primary, let's just look at primary because I think that's the easier example, where you're having a problem at the thyroid, your TSH will be high because your pituitary is constantly trying to tell that thyroid to work. It's saying, come on, let's produce hormones. Come on, let's produce hormones. Well, if it's primary and there's a problem with the thyroid, that T4 is still going to be low because it's having a difficult time producing, where your TSH is still high because it's trying to stimulate it, but it's not doing anything essentially. So that's the problem that originates right at the thyroid, where if you had secondary, your TSH is low because remember your pituitary is the one that's sending out your TSH. Well, if it's low, it's not sending TSH out to basically stimulate the thyroid. So there's a dysfunction up here. And then obviously your T4 is low because there's not a stimulating hormone there sending it out. Same thing with hyperthyroidism. So if hyperthyroidism means that there's excess thyroid hormone, where in this case, your TSH is low because it's basically your thyroid hormones are very high. It's going to shut this off. So it's basically like the thermostat example. It's going to shut off that pituitary and you're not going to have TSH coming out. So basically it's shutting off the TSH stimulation because it knows that your T4 is already high. So essentially the TSH is an area that we always look at. We always make sure, that that's the number one area that we screen with, the number one thing we look at. Obviously in conjunction with the T4 too. So like I mentioned, it's two different hormones that are stimulated, T3, T4. When we replace, a lot of times we put them on levothyroxine, which is like Synthroid, and it's a T4 hormone. As I already mentioned, affects growth, maturation of cells, cellular metabolism, heat production, oxygen consumption. This is just another example. The big things that I want you to take away is that we look at the TSH. So if a TSH is high, it's usually hypothyroidism because it's trying to stimulate that thyroid to work. And we'll look at these, as well, but like Hashimoto's basically is for hypothyroidism, but that's, if you notice here, we'll look at antibodies because these antibodies, with Hashimoto's and Graves', it's related to an autoimmune process. So it's basically they get destruction of that of the thyroid. And either with this, it's destroying it where they don't have production, or with Graves', it's actually stimulate to have hyperthyroidism. So a lot of these two are related to an autoimmune disorder. We already kind of talked about primary and secondary. And then sick euthyroid basically is, it's usually not an issue with the thyroid. It's an underlying disease state that causes, abnormalities in that thyroid hormones. But usually what we do with this, we don't treat the thyroid for that. It's actually treating the underlying illness. So it's usually someone that's really sick and then their thyroid hormones kind of get out of track. But the big thing I want you to understand overall is there's, basically primary and secondary. And you can have hyperthyroidism or you can have hypothyroidism. Like I already mentioned, we look at TSH. Elevated TSH is going to be an indicator of hypothyroidism because remember, TSH is a stimulating hormone. If your thyroid hormones are low, your TSH is going to bump up, basically trying to stimulate it. And then typically, if your TSH is off, we'll look at your T3, T4. We tend to look at the free T3 and T4. We're more focused on that because that's basically like the circulating levels of it. With hypothyroidism, you'll see a lot of different changes, as I mentioned. A lot of times these patients will have weight gain, they'll have fatigue, skin dryness, edema. I'll give you examples on the next slide. But if you can see the changes where, this is a patient with severe hypothyroidism versus their normal state. Same thing here. You can see the changes in their skin and their face and the edema that they have. These are some of the symptoms of hypothyroidism, which is very vague. So that's the thing. Like it could be multiple things that could be causing it. But that's why we look at the thyroid a lot for a lot of different problems that a patient presents with. They can have menstrual disturbances. So it can change a lot of those other hormones like your LH and FSH, which are secreted by your pituitary. It's stimulating from your pituitary, but they have a lot of changes like things like hair loss, dry skin, intolerance to cold, weight gain. They may have slow speech, facial edema, constipation's a big one. And what we worry about, and nowadays this tends to not happen because we usually catch it, but if they have late manifestations where it's very severe, they can obviously have like a downward spiral where it affects their heart and their, perfusion to their brain. And that's usually if someone had severe hypothyroidism and then had a really, really significant illness. Then they start having heart issues where it's slowing down the heart rate, and then they have lack of perfusion to the brain. But like I said, nowadays we pretty much catch this before it gets that bad. So when you think about hypothyroidism, think about everything that's slowing it down. Everything's slowed down. Whether it's constipation, slowed speech. They may have depression. That's another big one that you'll see too in patients. Or fatigue. Fatigue's a huge one too. Or hair loss. So these are the same kind of things. Pale, puffy face, cold, dry skin. So remember, it's like a lot to do with your metabolism. Lowered heart rate and temperature, lethargy or fatigue, cold intolerance or impaired mentality. In the older adult too, thyroid function tends to decline too as the older adult ages. But it's one thing that we think about. If they have new onset symptoms, it's really important to look at their thyroid. Usually it's most commonly related to a malfunction in the thyroid. It can happen where it's the parathyroid, but most of the time with the thyroid, it's from the thyroid. Very, very common to have Hashimoto's, which is basically an autoimmune disease. So Hashimoto's causes hypothyroidism. They may bounce back and forth between normal levels and lower levels, but unfortunately, a lot of times they kind of end with hypothyroidism, and they end up with having to have treatment for forever, essentially. As already mentioned, insufficient iodine, that's not necessarily that big of an issue in the United States, but it still is in underdeveloped nations. If a patient, this is another area that you'll see it with, if a patient had hyperthyroidism, like Graves', they can have significant health effects from that, so they have to treat hyperthyroidism. When hyperthyroidism is treated, it's either done with like radioactive iodine, or if a patient had thyroid carcinoma, they may have surgery on the thyroid. Well, what happens is that they end up with destruction of the thyroid. So unfortunately, patients that have hyperthyroidism, unfortunately kind of end up with hypothyroidism after treatment. So you'll see patients that were treated for hyper, and then they end up having to be on thyroid replacement because of the treatment they received. So that's not uncommon either. Insufficient secretion of TSH and TRH. So if there's a pituitary issue, then you may have, they're not getting TSH put out essentially from the pituitary. But it's more common to see it at the thyroid essentially. Graves' disease is basically the opposite. So we're talking about hyperthyroidism here. Graves' is another one that is developed from another autoimmune disorder. It's the most common form of hyperthyroidism. It's more common in women. Exophthalmos is basically enlarging where the eyes enlargen. I'll show you on the next slide. There's an image of it. But will present with Graves' disease. So Graves' disease is pretty significant. They will have really, really high elevated levels of thyroid hormone. Whereas a toxic nodular goiter, these patients can present with hyperthyroidism too, but they don't have it as severe as we would with Graves'. They don't end up with the effect on the eyes like that. Because basically with like nodules, and it's not uncommon for patients to have nodules on their thyroid, and sometimes the majority of times they're benign, but sometimes they can have where they secrete excess thyroid hormone from the nodules, and then they end up with hyperthyroidism because of it. And not all the time. Sometimes nodules are just there and they don't cause any issues. But if they do have nodules, it's something we look at. But basically, Graves' is autoimmune, and it's almost like a more severe where they end up with issues with their eyes. So in terms of hyperthyroidism, it's going to be the complete opposite. They're going to have intolerance to heat. They tend to have more fine, straight hair. Their metabolism is essentially speed up. They may have weight loss with it instead of weight gain. Tachycardia, so the cardiovascular system is going to be, stimulated. They're going to have elevated heart rates. They may have an increased blood pressure. They may have diarrhea. So it's the complete opposite of what you would see with hypothyroidism. So think about everything speeding up here. Still can have menstrual changes because it can affect their LH and FSH. They still can have edema, but like I said, most of it is like, if you think about hyper, think about everything being sped up. Like the big thing that we're concerned about too is tachycardia in the heart, because it's obviously not good for the heart to have this high level of stimulation essentially with it. This is the exophthalmos, where they get enlarging of the orbits of the eyes. And usually once it's treated, it usually goes back to normal. So treatment usually resolves this, but that's what you see with Graves' disease. With Graves, you'll see TSI. So a lot of times with these thyroid disorders that are caused by autoimmune dysfunction, we'll look at antibodies. So they look at the antibodies that are present that are targeting the thyroid. Treatment for hyperthyroidism is usually removal of thyroid tissue, whether it's radioactive iodine or medication that we use with the patient, which I know you'll cover in pharm. Destruction of thyroid tissue, like I already mentioned, suppression of thyroid synthesis, and sometimes we actually put patients on more of like a symptomatic treatment, like beta blockers. And I know you didn't have pharmacology, but obviously with beta blockers essentially target the beta receptors on the heart, which slow down the heart rate. So a big, net effect of beta blocker use is slowing the heart rate down and decreasing that sympathetic activity at the heart. Well, with hyperthyroidism, remember, like I mentioned, we're worried about tachycardia and increased blood pressure. So sometimes we'll use beta blockers to make sure that their heart rate is not significantly elevated, if that makes sense. Radioactive iodine is another treatment that's used. I kind of already went through these, but as I mentioned, the big thing, we're going to look at TSH levels. If the TSH levels are high, that usually means that they have hypothyroidism. So remember, high TSH is coming from the pituitary. So it's trying to stimulate the thyroid to make thyroid hormones. So a lot of times their thyroid levels will be low. I know this is probably confusing, but subclinical hypothyroidism, and I don't think you really need to know all this, but essentially these patients don't have presenting symptoms of hypothyroidism, but their levels may be off. But we have like watchful waiting with these patients because sometimes they transition over to having symptoms with it. If you have, I wouldn't really worry about this, but if you want to think about it, if you have a high TSH and a high T4 level, if it's originating from the pituitary, it's because that it's putting out a lot of TSH and basically causing a lot of T4. So that would be pituitary hyperthyroidism, which I don't think you really need to go that far into this yet. I just want you to understand what we use to screen, like your TSH, and that the TSH is basically going to be high with hypo, and typically it's going to be low with hyper, because remember, it's in response to the thyroid hormones, if that makes sense. This is just an example of blood work. For instance, this patient's TSH is less than 0.03, and you'll see that reported out where it's actually less than the recommended range. So if it's less than, think about what it means. If they have a TSH that's extremely low, what does that mean? It means that basically the thermostat is being shut off. So then, obviously, this patient probably has higher end normal levels of thyroid hormone. And they do. I mean, it's not above normal, but it's high. So I just wanted to put that up there for that. So as I mentioned, TSH is the area that we use to screen for the thyroid. This is just a good question. I thought would be good to go through. If you expand on the PowerPoint, you can read the bottom part. Which of the following is true regarding thyroid hormone and thyroid stimulating hormone? TSH secretion is controlled by positive feedback. TSH is secreted in excess when stimulated by T4. TSH secretion is regulated by thyrotropin releasing hormone. Decreased pituitary release of TSH stimulates thyroid hormone secretion. TSH is secreted when thyroid hormones are increased. Okay, so get rid of the ones that you know it's not. So we're looking for what is true regarding the thyroid hormone and TSH. So TSH secretion is controlled by positive feedback. Is that true? No, it's negative feedback, remember? It's going back up and your thyroid hormones are shutting it on or off. So it's negative feedback. It's going back. TSH is secreted in excess when stimulated by T4. No, that's not necessarily true either. Remember, your T4, your thyroid hormones, are what controls your TRH and your TSH. TSH secretion is regulated by TRH. Okay, that is probably true. Decreased anterior pituitary release of TSH stimulates thyroid hormone secretion. Does that make sense? Think about that one. It wouldn't make sense, okay? Because if you have a release of TSH, I'm sorry, decreased anterior pituitary release of TH stimulates thyroid hormone secretion. TSH is secreted when thyroid hormones are increased. So no, that's the opposite. So if your thyroid hormones are increased, the TSH is going to basically be shut off. Does that make sense? So just try to think about it and put it in perspective. So the answer is C. TSH secretion is regulated by TRH. Because D is false, because TSH would be secreted if the thyroid hormones are low, if that makes sense. So, in terms of your parathyroid, and I'll talk about this in the next PowerPoint, but they're right basically in the same area of your thyroid. You have them on both sides of the thyroid, the upper and lower poles, but they produce parathyroid hormone. Your parathyroid hormone has a significant impact on your calcium and phosphate levels, and we'll talk about this in the next PowerPoint too. I just wanted to briefly cover it. And then the other area that it has a significant impact on is your bones. So basically it's an antagonist of calcitonin, which increases bone resorption and serum calcium. So it has a significant effect on, calcium levels in the bone and in the blood. And we'll talk about this when we get to the other PowerPoint. Vitamin D is needed for parathyroid function, so that's why nowadays too, like if you have a patient that has osteoporosis, we have to make sure that they're getting calcium and vitamin D because you need vitamin D, to support parathyroid function. But we'll talk about this in the next PowerPoint. So once again, going back to this, I wanted to give you a few other examples because we'll cover the other ones in class. I wanted to cover like your antidiuretic hormone in class, but even your cortisol levels, we're going to cover that with the other PowerPoint. But I wanted to give you a couple examples like the thyroid, and the next one we'll look at is growth hormone. But once again, remember, all of this originates your hypothalamus, your pituitary, and then it goes out to the glands. So when we look at growth hormone, which let's go back actually, growth hormone obviously same type of thing. You have your anterior pituitary, which is stimulating growth hormone for bones and tissue support. So obviously your growth hormone promotes growth. Obviously it's really important in the child or adolescent because this is what promotes growth and development. Protein synthesis and carbohydrate metabolism. So even growth of your tissues, your muscles, your bones, etc. In terms of physiology, regulation of release, I already kind of mentioned all of this is in concert with your hypothalamus and pituitary. It promotes protein synthesis and has effect on carbohydrate metabolism, which is actually a repeat of what I have at the top. This looks complicated, but I added this on here so it would give you a picture to kind of put it with. So once again, remember your releasing hormones are sent from your hypothalamus. So remember everything releasing comes from here. And then basically your stimulating hormones all come from here. So your growth hormone is basically, it's released out here and then it stimulates growth hormone. But what happens is that with growth hormone release, it's actually most commonly a pituitary adenoma that can cause excess growth hormone, most commonly in the adult. But in the child, they don't have support of, if you had a negative growth hormone release, you're going to have a net effect on the bones, your muscle cells, your nervous system, your immune system. So you're going to have a deficient state there, which does not, if you hit a low level, then you're going to have, obviously they're not going to have great growth of their muscles or their bones, essentially. It does have an effect on glucose levels as well. So a lot of times, if a patient had excess growth hormone, they can have or be at risk for hyperglycemia too with it, because it does have an effect on the release of glucose at the liver. The other thing too I always try to mention with this section is patients that take growth hormones, or, people that are in weightlifting and they take growth hormones or testosterone. And unfortunately, what happens with this is it kind of shuts off your normal body system, like your normal neuroendocrine system. And it's the same concept too, which we'll talk about during class, of like cortisol and like having patients on high dose steroids. What happens is their body becomes dependent upon whether it's growth hormone or steroids. That's what's kind of regulating their endocrine system, like an external exogenous form of growth hormone. So let's say if somebody was taking growth hormone to increase muscle mass. Well, what happens is it shuts off like your normal hypothalamic pituitary axis. So if they were to stop taking it, all of this kind of goes haywire, and it doesn't function right anymore. And it takes some months and months to go back to normal, essentially. So really, like when when patients think, oh, like you think about, because I work in sports medicine too, but like patients that take like growth hormone or testosterone supplements, it really, really messes up your hypothalamic pituitary axis, because you're getting an exogenous source and then it shuts everything off. So when you withdraw that exogenous source, whether it's growth hormone, none of this is really working right anymore. So then they can't produce it on their own. So then their system's really haywire afterwards, and it can affect like their testosterone levels and all of that. But I always bring that up because it's just like an interesting point to think about when you talk about growth hormone and things like that. But really, they're doing themselves a disservice, because obviously, it shuts off your normal hypothalamic pituitary axis, and then you have a whole slew of problems after that. So if a patient has deficient growth hormone in the child, obviously it's very, very problematic. I mean, it's problematic in the adult too, but this is what basically causes short stature, slowed growth. Mental function is not impaired. It's not affecting the brain or anything like that, but it definitely affects their growth. So if, we'll always look at growth trends in a pediatric patient. If they don't have a steady incline in growth, or they all of a sudden have a drop, it's something that we think about. And a lot of times, as I mentioned, this is related to like a function or an issue functioning in the pituitary. It's originating from that pituitary. That's where the problem is. In the adult, as people age, the growth hormone does reduce. So that's why a lot of times too, like muscle mass is reduced in the older adult. But obviously, if it's really low, they can have like reduced muscle mass in the adult. Excess growth hormone is hyperfunction from the pituitary. It's the same thing. It's originating from the pituitary. In the pediatric population, you think about their growth curve, they're going to have excessive growth. So if they had excess growth hormone, they could be very, very large and very, very tall. As I mentioned, a lot of this results from the pituitary gland or a pituitary adenoma. So we always look at the pituitary, whether it's like an MRI, to see if there's like an adenoma there that's, stimulating this essentially. In the adult, they call it acromegaly. Acromegaly essentially is like an enlarging of the bones and muscles essentially, because if you think about it, your epiphysis essentially is at the end of long bones. In the child, like musculoskeletal wise, they're at the end of long bones. Those epiphyses are not closed, meaning that's what causes growth of long bones, and that's how the child and adolescent can grow, because they're still open. The growth plate's still open, so they can still grow. While in the adult, those close. Over time, your growth plates close. Well, if they're closed, instead of it growing long, what happens is it grows wide. So that's why they get acromegaly. Acromegaly means basically enlarged bones or or tissues essentially. So in the adult, excess growth hormone is going to present with acromegaly. We always look at the pituitary, because that's where it's coming from. And it's not uncommon for it to be a pituitary adenoma that's causing this essentially. So like I mentioned, and it depends too on the timing of growth hormone in the child. If it begins before puberty, this is obviously really problematic. That's where dwarfism can occur. There's different types of dwarfism, and I'll show you on the next slide. But this one, if it's from growth hormone, it's more of a, actually, let me show you. They tend to have like their long bones, it's all proportionate to one another. I guess that's how I should say it, with growth hormone. Where achondroplasia is actually another form of dwarfism, where they'll have like shorter long bones in the legs. That's different. This is basically more of a proportionate growth deficiency. Like if you look at this child, it's all, it's proportionate to one another. Where there's achondroplasia, where they have lengthening of just like the long bones. So they may have like a longer torso with shorter legs. So that's different. But growth hormone, obviously, they could have dwarfism if it's before puberty. If it's after puberty, then that's when they start having more issues with like their muscle mass and bone strength. Or in the adult, they tend to have decreased muscle mass. Where the opposite, like I mentioned before, they can have gigantism because they have excess growth hormone. So that would be if they had it before puberty or, during adolescence where they're still growing. And as I mentioned, excess growth hormone in the adult, they'll have their joint enlargement. So like they could have a pituitary tumor because the growth plates are closed. They tend up just growing larger like that. Or you look at the foot here. So it's a little bit different in the adult. Real quick, prolactin. Prolactin is produced by your anterior pituitary, so it's another one that's from the anterior portion. This is what stimulates milk production after basically giving birth to a baby. But we can see elevated prolactin levels with a pituitary tumor too. So if you have a patient that had galactorrhea, so galactorrhea means secretion of milk from the breast, essentially. If they have galactorrhea that presents in a male or female, and there's other reasons for it too that it can happen. It's not always that there's a pituitary problem, but we always look at the pituitary with this as well, because if they're producing milk, it's coming usually from that anterior pituitary. So basically with this, and that's how milk is produced essentially even too, like after pregnancy. But in women, that's what brings on it. If actually, I know it's confusing, but it starts affecting your LH and FSH, which is what controls your menstrual cycle. So that's why when women breastfeed, they have amenorrhea and they're basically infertile at that time. You can't, not to say you can't, but you typically cannot get pregnant when you're breastfeeding. And it's because of prolactin levels and the interplay that it has on your LH and FSH. It's probably a little more than you need to know, but that's why when women are breastfeeding, typically they don't have periods at that point, and they can't usually get pregnant. But in men, it can happen too, because it can happen from the pituitary. But they can have galactorrhea, once again with that, or they can have issues with delayed puberty too, because it affects their other reproductive hormones as well. Antidiuretic hormone, we'll talk about this with the other PowerPoint. I just wanted to briefly bring it up. Your antidiuretic hormone essentially is coming from your posterior, it's actually your hypothalamus it's produced in, but it's coming from the posterior pituitary. So the only ones that come from the posterior is oxytocin and your antidiuretic hormone. And when you think back, antidiuretic hormone has what does it do? Think about it in the effect of your cardiovascular system. Because basically that's what's maintaining our blood volume. It has a significant effect on that. So basically the permeability of water and your kidneys holding onto water is essentially regulated by antidiuretic hormone. Sometimes you'll hear the term vasopressin. That's what it's also known as. But basically with this, it's the posterior pituitary and has a significant effect on your blood volume. But we'll talk about this too with the next PowerPoint. This is just a good image going back to like your antidiuretic hormone. It senses that rise in osmolarity. So remember what osmolarity is? So it's basically the concentration of solutes in your blood. And think about what does antidiuretic hormone do? And we'll talk about this with the next PowerPoint in more detail. But I just want to get you thinking about what the outcome of it could be. If you have a deficiency in antidiuretic hormone or an excess in antidiuretic hormone, what happens? So think about that, but we'll talk about it with the next PowerPoint too. That will conclude the lecture on this first portion of hormone regulation. And obviously we'll talk about a lot of this more in detail, like your antidiuretic hormone. We'll look at your adrenal hormones, diabetes, things like that too within the next PowerPoint. So this one I really want you to think about. Number one, think about negative feedback. I want you to understand that. How does it happen? Where does it start? And what is negative feedback? Also think about things like just very general, like with your thyroid, like what the symptoms are with hypothyroidism, what are the symptoms with hyperthyroidism. And I also want you to think about like antidiuretic hormone. What would happen if it was insufficient, or what would happen if it's elevated? So these are just things to start thinking about, and then we'll cover a lot of this in more detail. So this one, I just want you to really get a good understanding of like negative feedback and how the neuroendocrine system essentially works. If you have any further questions in the meantime, please let me know. Thanks. I hope you have a great day.